Okay, let's now talk about PE, otherwise known as pulmonary embolism. So there's a variation in the extent of a PE that a patient can have. It's either massive or submassive. The massive PE blocks a lobar or larger artery with infarction of lung tissue. Severe shock death often occur within 2 hours after event, and history has shown that, or rather research has shown that 10% die in the first hour. Submassive is a shower to distal branches of the lungs. It's more common and less severe, and it's also treatable. This is a picture of pulmonary emboli. As you can see, it's completely blocking, and I doubt that this patient survived. So some of the physiological changes that occurs with a PE is decreased oxygenation, hypoxia leading to vasoconstriction of the pulmonary artery, resulting in pulmonary hypertension, decreased surfactant leading to alveolar collapse and atelectasis, peripheral edema from right ventricular failure caused by pulmonary hypertension, and then histamine release and decreased cardiac output may cause hypotension. Whenever you see patients that have experienced a PE, you'll notice that they have anxiety symptoms. They feel like they can't breathe, or the world is collapsing around them. And so it's very traumatic for patients. And so whenever patients are having these symptoms, if you suspect a PE, early intervention is very important. So some of the assessments you could do for patients with PE is dyspnea, pleuritic chest pain. They may have cough, hemoptysis. I will say the pleuritic chest pain is sharp chest pain. And then, of course, they're going to experience hypotension. I am mentioning the hypotension because I don't see it on here, but it's one of those things that patient could have. And also, it's very important for your future reference, meaning next week. The patient will also have cough, hemoptysis, diaphoresis, syncope, tachypnea, tachycardia, crackles, decreased breath sounds, wheezing, JVD, low O2 levels, low-grade temp, and most importantly, anxiety. Like I mentioned before, patient feels like they cannot breathe and they're having a hard time they get super anxious. If you see a patient having a PE, it will never leave your mind. Let's just put it that way. So diagnosis for PE, the D-dimer elevates. D-dimer measures fibrin degradation products released. If normal, unlikely that the patient has a PE. And then also we do Doppler studies of legs, determines location and extent of thrombus within the leg veins. Remember, DVT leads to PE, and so presence of a DVT will let us know where the origination was. This is an algorithm for suspected DVT and what actions to do. So if you suspect a DVT, the first action will be ultrasound, proximal veins to cuff trifurcation, and then if positive, then you treat the DVT. And how do you treat for DVT is by putting patients on anticoagulants. And if it's negative after the ultrasound, we'll do a D-dimer. The D-dimer then, if it's negative, then DVT is excluded. But if the D-dimer is positive, then we'll do an ultrasound, follow-up ultrasound in 1 week. Another test is the VQ scan. Patient must be able to lie still and breathe the gas and have dye injected. For the most part, if patients are having respiratory issues or they have kidney compromised, then they may not be able to handle the dye injection. And then also if they're having anxiety and they're having trouble breathing, it's hard for them to lie still, of course. And then the other one is pulmonary angiogram, which is invasive and it's used to visualize the vascular system. And also they can inject clot busters. This is a little bit extreme and mostly done for bigger emboli. The other one is the helico-CT. It's becoming the most common visualizing technique. It requires a dye, causes diuresis, not appropriate for renal failure. Like I mentioned before, anytime you're using a dye, you have to consider patient's renal status, and if the renal status is compromised, then this will not be an appropriate test for them. Patient may have mild nausea, salty taste, and warmth with the dye. This is a positive VQ scan. There are areas of white in the lungs show no gas distribution. So this is right there, and then right there, and right there. The multiple white areas show a shower of pulmonary emboli. So you can see how much it's distributed there on the chest CT. So management of a patient with PE is elevate the head of bed, or 2 cannula or non-rebreather to deliver highest concentration of oxygen if saturation is low. So it's important to note that oxygen is one of those things that you can give without a doctor's order and then obtain an order afterwards. In the immediate, when you in the patient's room and they're having trouble breathing and their O2 saturation is low, your immediate intervention will be to make sure they get as much oxygenation as possible, and that includes elevating their head and then putting a nasal cannula on them. You can start with the O2 levels as low as 2 liters and then go up from there, and then immediately call the doctor to let them know what's going on. Vital signs should be done frequently, and patients are usually transferred to the ICU if they are unstable for intubation, especially when it's a massive PE. That's an automatic ICU transfer because these patients need to be monitored closely and under critical condition. So here are some of the anticoagulants, and I talked about the heparin on the other lecture. So heparin drip is started right away unless contraindicated. Monitor partial prothrombin time, but the latest monitoring we do is anti-XA, but they are monitored in conjunction with the PTT. So if you see the PTT, don't be surprised. Otherwise, the standard is to monitor the anti-XA. And then warfarin is started later after the patient is stable. and it takes about 3 days to get therapeutic. In this case, and I repeat this intentionally so you can have it in your mind, that a patient on heparin drip, for the most part, will also be on Coumadin, and then the heparin drip will be stopped later, just so the INR levels to 2 to 2.5 times the normal level, which is considered a therapeutic range. During IV heparin drip, make sure patients' platelets are monitored, because dropping platelets are a side effect of heparin, in which case we also term it thrombocytopenia. Be sure to learn about the reversal agent for heparin. Check interactions with other drugs. Many inactivate or increase effects. IV peak for heparin is 2 hours and duration is 2 to 6 hours. And like I mentioned before, we can have patients on heparin drip until a few hours before surgery, especially if the doctors are concerned about patient having a clot when they stop the heparin right before the surgery. Oh, here it is. So this is a heparin drip implementation protocol. So the anti-XA and PTT and CBC, so the CBC includes the platelet and hemoglobin levels. You want to know that the patient is stable enough to be able to handle the anticoagulation. So this is done, and then it's followed by a heparin bolus of 80 units per kilogram. This is why it's very important to always weigh the patients upon admission or on a daily basis, depending on what the situation is. The heparin is always via IV drip using a pump, because this is a risky drug, and so you do not want to make a mistake with this one. And a second RN is always required to verify the rate, and then also make sure you check the orders. Sometimes it's ordered based on the patient's weight, or it's predetermined by pharmacy what the initial rate should be. Know the current anti-XA and when the next anti-XA should be drawn. Normally the monitoring for anti-XA is every 6 hours, but depending on what the patient's condition is. So initially the anti-XA is drawn, and then the heparin drip is started, and 6 hours later we need to check the anti-XA. Be prepared to change the units received per hour based on the current anti-XA. The good thing with technology is that the calculator is actually embedded in the MAR. So whenever we're administering heparin, all you have to do is click on the calculator or the guideline, and it will show you exactly how to adjust the rate. And if there's no rate adjustment needed, if say the anti-XA comes back normal, you need a second anti-XA to confirm that it's normal before you can defer the monitoring to Q daily or QAM. Know the desired anti-XA range physician determines based on risk for thrombus formation and patient history. And anytime you're not sure, always consult either pharmacy or the doctor. I'll highly recommend contacting the pharmacist, because they do have a coagulation pharmacist in-house, and they're familiar with all the nooks and crannies of ordering heparin. Some doctors may not be as familiar because they don't do it as often, especially a teaching hospital like UC Davis, most of the doctors are residents and they're also learning. So it will be a good idea to check with a pharmacist who is familiar with the protocols. So this is a sliding scale for anti-XA and heparin. So if you study this table, you'll be adjusting according to what the anti-XA says and what the order says. So be careful when you're monitoring these two. Some of the aggressive management available for managing PE is thrombolytic agents to dissolve the PE. It is very expensive and it's not a good idea if patient has had recent surgery or trauma, and you are going to learn about it more next semester. In this case, we're talking about TPA. Another intervention is the inferior vena cava filters. This particular one is not used much anymore. Evidence-based practice does not support because of the lack of good outcomes. So we're always all about good outcomes, and so if we do not have good outcomes, then we tend to stay away from it. So evaluation, patient education, the key thing is prevention. So you're preventing the patients from getting blood clots, because blood clots are really, really bad, and blood clots lead to PE if not treated. And then you want to teach patients about the anticoagulants, especially Coumadin. Coumadin is the most difficult thing to manage in the community because it requires weekly monitoring and weekly adjustments, and most primary doctors have a hard time doing this, and so they prefer sending patients to the Coumadin clinics where the medical providers there can manage the patient's adjustments, because the doses can change on a daily basis or on a weekly basis. When I used to work primary care, we'll have to adjust, say patient should take 2 milligrams today and then 5 milligrams every other day. It can get really confusing and to keep up. And especially patients who are elderly and need the Coumadin for specific reasons, like say atrial fibrillation. That's one of the conditions that's very common in the elderly, and almost every other person is on Coumadin. And so for them to have to remember, like say on Monday I should take 2 milligrams and then on Tuesday I should take 5 milligrams, it can get super confusing. And then evaluation, oxygenation, the rate, pulse oximeter, dyspnea. Is the patient's oxygen saturation okay? And are they having dyspnea? Coagulation studies, the PTT like I mentioned, and then PTT and anti-XA. That should be updated in there. And then INR and prothrombin time with the Coumadin. Basically INR, let's put it that way. And that is the end of our study for pulmonary embolism. Just be sure to understand the symptoms for pulmonary embolism, which are hemoptysis, sharp chest pain, hypotension, And then some of the diagnostic tests, which are chest CT, VQ scan, Doppler studies, and the D-dimer. And I already emphasized the fact that you can start Coumadin before the heparin is discontinued.